Welcome back, everyone. I can't believe it. We are at our final presenter, and this final presentation is going to be done by a good friend of WPA's, Dr. Michael Schonberger. Dr. Schonberger is a movement disorder specialist at Gundersen Health System in La Crosse, where he has reestablished the deep brain stimulation program and is also involved in training medical students and residents. He's a member of WPA's Medical Advisory Committee. Welcome, Dr. Schonberger.
Hello, good afternoon, everybody, and thank you for this wonderful opportunity to speak before you. It is a great honor to join you from the west side of the state, and hope the day's weather is a little more beautiful for everyone else. Hope everyone is staying safe, of course. Today's topic that was given to me is something that's really near and dear to my heart, the role of care partners in Parkinson's disease. I'll talk more about this as we go through, but this is going to be less of a factual knowledge point talk and more so things that I've experienced during my time both in training and in practice since arriving here in Wisconsin. So I'd like to thank again everyone, especially the Wisconsin Parkinson Association and Gundersen Health System, and of course all of you for joining in and tolerating me for the next several minutes. Next slide, please. So again, as many probably have, I'm supposed to tell you that I have no financial disclosures to report, even though I'm still not entirely sure what a financial disclosure is. I have not received any compensation of any kind for today's presentation, although God knows I could use some help with my student loans, but that's a totally separate topic. Next slide, please. But there is another set of disclosures I would like to make, and that's personal. Why is this topic so important to me? Practicing medicine in the real world is very unlike what they teach you in medical school. And it really shows you just how much everything from not just care practices, but care philosophies and care roles are, vary over geographical distributions, over socioeconomic distributions, and how naive I was when I first started this little journey of mine, how I realized the prejudices that I came with and what I did next to try to fix them and correct them. So next slide, please. Basically, I've divided this talk into three sections. Number one, when does the care partner's role begin? And then why care partners are so important and then finally, what are the needs of the care partners themselves? Next slide, please. But before all of that, I have to warn you that I do have some very corny, cliche-ish stuff to add. Wisconsin being the dairy land, some of my humor is very cheesy, so be prepared. Here's your warning. So next slide, please. So the first thing is, what is a care partner? And this is in no particular order. So a little correlation is back in the ancient times, certain societies believed that everything was made up of four elements. Well, I kind of see that in what makes up a care partner. So in no particular order, a care partner is a mind who can provide history and insight, a body who can help people move easier by being a helping hand or just listening, a heart, which is companionship and the source of love and support, and then a soul or a conscience, depending on what term you prefer, to aid in sticking true to yourself, being accountable and following whatever, rules per se there is. Next slide, please. So when does the care partner's role begin? Right at the beginning. And what it begins with is a combination of honesty and communication. And I want to emphasize that in no way, shape, or form am I ever going to imply to you during this talk that any of this is easy. Okay? This is not easy. We all know that this is a very challenging process for everyone involved. It's very strenuous. And while it's not easy, there are some things that can be done to make it easier. So next slide, please. So again, if you think about yourself as the care partner, or if you have Parkinson's disease and you're thinking about whoever is your care partner, be it a loved one, family, friend, any sort of support, I want you to picture that care partner for a minute. And I want you to think of that care partner kind of staring at themselves in the mirror. And you have to be honest with yourself that you are seeing a change in the patient, one way or the other. And you all know about the non-motor versus motor signs of the condition. I'm not going to belabor that, but it takes a strength and honesty to be able to look at yourself and say, I'm not imagining things. I am seeing these changes in this person that I care so deeply about. And then the next step is looking at the patient and being honest with them about what you see and doing the unfavorable task of maybe opening their eyes to what's going on, and even harder, convincing them to seek help, okay? The next step is communicating with the healthcare provider, okay? Being honest with the history and the treatment. And then something that I think some people overlook that was new to me when I started practicing was looking at the support system and being honest with the loved ones of the patient. And we'll get more into this point later on. And then it's just a matter of lather, rinse, and repeat of how this goes. So next slide, please. So let's begin. Communicating with the patient. So again, what have you noticed in them versus what they are themselves aware of? And again, this goes everything to the motor features of, hey, I've noticed that you're not walking as briskly as you were, or you're shaking a little more than you used to. Your voice is a little softer. You look a little more flexed in your posture, stooped, and you don't look as expressive as you used to be. And then, of course, everything else that goes along with this. I realize you've been struggling with constipation lately. You've looked very dizzy sometimes when you stand up. And when you sleep, you move around a lot. Okay? So, and again, a lot of these things at the onset, a lot of patients don't notice themselves, and it does take someone else to point it out to them. And it has to be a very honest and open discussion about the changes and concerns that you as a care partner have, okay? And this is, again, not an easy thing for either side of the support system, okay? There are some people who just cannot readily accept that this may be going on. And it takes a very special kind of emotional support to be a shoulder to lean on, to just look them in the eyes and say with as much lovingly tone as you can, I'm concerned about this, okay? And then a lot of people need encouragement to seek out medical care, education, and resource support. So that all plays together. Next slide, please. And it first starts in the office with when communicating with the healthcare providers with the history in order to make the correct diagnosis. And again, I know probably several of the previous speakers have, drilled this into you ad nauseum, not to mention any of the healthcare providers that you've seen. But when a patient first comes to us and somebody is sending them to us for concerns of possible Parkinson's, again, we start by using this term Parkinsonism, which is this umbrella term that encompasses Parkinson's disease and the other conditions that we know mimic Parkinson's disease, but are different in some way, shape, or form. And at the initial appointment, it's not always easy to tell which from which is why we really need to put on our hard hats, grab our pickaxes, and do a lot of digging. Next slide, please. So this graph comes from courtesy of one of the gurus of movement disorders in America, Dr. Joseph Jankovic, who came to America reportedly with not much in his pocket. And now he's one of the biggest movement disorders experts down at Baylor in Texas. And the point that I'm trying to make here by showing this to you is that when we are faced with a Parkinsonian-like picture, this is the differential diagnosis, the overlap of everything that can resemble part or portions of Parkinson's disease, either motor or non-motor or a combination. And this is the challenge that we as healthcare providers need to wiggle out. Next page, please. Now, again, when it comes to communicating with the healthcare providers, and if any of you have been unlucky enough to be in the same room as me, you'll know that the first rule is I always allow the patient the chance to start the conversation, okay? What have they noticed, okay? And there's a bunch of very essential historical questions that we need to be able to try to answer as best we can in order to not only clinch the right diagnosis, but offer the proper ideal treatment, okay? So a lot of this is, when do the symptoms begin, okay? When we started noticing this, was there any inciting event? Was there a trauma, an infection, an injury, a medication change when we started noticing these symptoms? And again, depending on who you talk to and who you read, you'll recall that the motor features of Parkinson's disease appear after anywhere from 60 to 80% of the dopamine producing cells have already died off, okay? And again, that range varies, depends on who you talk to or whose work you read. So again, collecting these historical tidbits to present at the appointments, and then also gathering previous medical records can be a big help and a big time saver to getting the patients the right care. Again, what were the initial symptoms, okay? This is important because different conditions can present with different features, okay? So when we think of Parkinson's disease, just for an example, we're looking for the slowness of movement, the bradykinesia, the tremors, the, gait or walking challenges. And then flip it to some of the mimickers. Maybe some of the initial symptoms had to do more with cognition or memory or hallucinations, or delusions, or if the patient's initial symptoms were related to freezing up and falling before they even developed anything else. Did the symptoms start on one side and progress to the other, or did they start on both sides seemingly at the same time? All of these things are prognostic clues and information, okay? Of course, when you see me, am I the first neurologist you've ever seen? If not, have there been any previous attempts to treat? Any conservative means like physical therapy, occupational therapy, speech therapy, medications, and of course, have there been any tests that have been done, either medical imaging or any other blood tests or ancillary tests to try and figure out what's going on here? Next slide, please. Continuing the communication with the healthcare providers, again, the timeline of symptoms, the chronology of it all is, again, extremely important for many reasons, especially because a lot of the non-motor symptoms, patients can be very, very hesitant to bring up, including memory or mood changes or disorders, changes in bowel and or bladder function, changes in sleeping, maybe the partner in the bed with them has noticed that they tend to flail around or talk a lot or act as though they're acting out their dreams. Sexual dysfunction is another very delicate topic to bring up, as is the concept of hallucinations or delusions, because we don't want people to think we're crazy, is the quote that I often get. And then anything like from getting lightheaded when you're standing or walking, which can lead to falls or fainting, okay? And it's in that moment that the clearer the picture we have, the more supportive the care partner can be, and the more supportive the provider can be to help reassure the patients that none of this is anything they should be ashamed of or scared of to share. We want people to feel to be as open as honest as possible. Okay, next slide, please. Now, again, once we move past the symptomatology, now we start getting into a lot of more sensitive areas, okay? In terms of what specific actions or concerns a patient or yourself as the care partner may be concerned about, and chief among them will be safety, okay? Do you think you need any changes made to your home, such as adding grab bars to the shower, making sure there are no loose rugs or carpets, any trip hazards? We have to have the uncomfortable conversation about maybe the need for an assistive walking device. Now, I will tell you, even though, relatively speaking, my practice career time has been relatively shorter than maybe a couple of the other providers who have presented, I can say with assurance, I have yet to meet anyone who likes using a walker, okay? I don't know anyone who likes using a walker, who's happy to use a walker. But I will tell you this, I know people who prefer that to falling, okay? Driving ability is also something that we have to have a frank conversation about, especially due to the slowness in responsiveness and processing, in addition to the slowness of movement and reacting. Swallowing difficulties, this is not something I play around with. I am constantly checking at every appointment to see if somebody is having difficulty swallowing. Solids, liquids, pills, all of the above. Have they actually been choking to the point that they need the Heimlich maneuver or other sort of emergency intervention? or are they just having repeated coughing spells? I'm very quick to pull the trigger for a speech and swallowing evaluation. I don't like my patients choking. That's kind of bad form. And then the need for additional and outside help. And we're going to talk a little bit about that more coming up. Next slide, please. And we also have to look at the patients, at your entire medical history that may contribute to some of your symptoms. And chief among them, in my experience, is anything that could contribute to a loss of balance or falls, okay? And one of the most common contributing factors to that may be a lack of sensation in the feet, or a process that we call a peripheral neuropathy, which interferes with how well somebody feels the ground and therefore impacts their ability to stay steady and prevent falls, okay? The list of potential causes of peripheral neuropathy is about as long as I am tall. Sometimes we don't find an answer, but the potential most common causes in America, especially, are diabetes and chronic and or heavy alcohol use. But also on the list are vitamin deficiencies and toxicities. Also on the list are diseases, chronic kidney disease and thyroid disease, as well as blood protein abnormalities that can contribute to this lack of sensation. So if I'm examining someone and I suspect that there's something going on here balance-wise besides just a movement disorder, I will order tests to try and delve into that. And again, a peripheral neuropathy refers to the nerves in the peripheral nervous system, okay? Versus the central nervous system, which is the brain and spinal cord. And we know Parkinson's disease is a central nervous system process. A peripheral neuropathy, by definition, is a peripheral nervous system process. And in general, although with some rare exceptions, these two processes really have nothing to do with one another, since they originate from different parts of the nervous system, but they both cause imbalance and they both increase your risk of falling. When it comes to sleep disorders or disruptions, we have to take a look at what is lovingly referred to as sleep hygiene, okay? Are you going to bed at the same time every night? Are you waking up at the same time every morning? Are you taking naps during the day? Do you wake up feeling rested? Okay, and this can have a number of implications beyond physical mobility in the realms of memory and mood and other behavioral changes. And then, of course, the hydration practices, because we know that dehydration contributes to the postural lightheadedness, which could be due to orthostatic hypotension, again, your blood pressure dropping when you stand up, as well as constipation, because the more water, the less hydrated you are, the more likely you are to be dealing with constipation. Next slide, please. Family history is critical. As we learn more and more about the genetics of movement disorders, it is imperative that we do our best to try to get a good family history of movement disorders, other neurological disorders or conditions, any psychiatric conditions, and any substance abuse disorders, okay? And why are the latter two that I mentioned here so important? Well, it's because when it comes to psychiatric conditions, there are implications that certain medications can bring on Parkinsonian-like features, as we know, but that's not true Parkinson's disease. That's what we call drug-induced Parkinsonism, okay? And then when it comes to the substance abuse disorders, as I'll talk a little bit more later on, this can help us determine if there's a particular class of Parkinson medications that we should steer clear of for one reason or another. And then the social history, again, any history of tobacco, alcohol, illicit drugs, any issues with sexual impulsivity or sexually transmitted disease is something that we need to assess for the very same reasons. Next slide, please. So, and this is just an example of what I try to get from the patients and or their care partners. If we were to just take carbidopa levodopa as an example, as our prime example, since that medicine is old number one, it's still the gold standard, there are some treatment response questions that we try to answer at every appointment if possible, including, can you feel it kick in? How long does it take to kick in? Can you feel it wear off? And if so, does it wear off gradually or does it wear off abruptly? How long do the doses last? What does the medicine seem to help with specifically? Now, you can't just say, yeah, I think it's helping. Okay, good, but we want to know with what. And then finally, what side effects are you having, if any? And again, these answers dictate how we go about adjusting treatments. Next slide, please. And then finally, communicating with the support system. It goes without saying that isolation tends to foster depression and feelings of shame. And a lot of patients who, as time goes on and their symptoms progress, may express feelings like they are a burden to their care partners, to their loved ones, and they feel ashamed in needing the help that they do. Now, I used to think that I will admit, I had the naive prejudice or the naive thought that anyone who exhibited any of these changes would want their loved ones to know for one reason or another. But it turns out that I do have a few patients who don't want to tell their family and friends about their new diagnosis. And that was a new mentality that I encountered that I honestly didn't expect. So we try to get into the whys and why nots, again, to see if we can help with any sort of support in that way. And then again, support groups, which are and organizations that are so wonderful, like the WPA, help people to realize you're not alone. But it's also very important that we remember Parkinson's disease, even though the defining characteristics are quote unquote accepted as being universal, not everybody progresses in the same way. And that's a cheesy cliche, but it is actually the truth. So as you're sitting wherever you are today, or if you're ever in a support group, and you look to your right and you look to the left, and you notice that another patient looks different from you, maybe better, maybe worse in your perception, it's very important that we all remember, both patients, providers, and care partners alike, we should never be comparing ourselves to someone else that we know has Parkinson's. Forget apples to oranges. This is apples to bowling balls, okay? This is not fair to get into, and you can only make yourself more frustrated by it. Next page, please. And then a care partner's role as time goes on. Unfortunately, as you all know, Parkinson's disease is progressive. And as things progress, we develop several more complications to the condition, many of which are listed as on the slide that you see here, and several of which many people are very hesitant to bring up. And unfortunately, next slide, please. One of the most common ones to deal with is regards to any changes in memory or cognition, okay? We always get asked, we find ourselves being asked, how common or normal is memory loss or problems thinking or finding words or problem solving issues? How often can we expect that? And that's a very difficult question to answer because people may already have other conditions that predispose them to memory loss. Anything from medications to other medical conditions that are not neurologic, to sleep disorders, things of that nature. And it's important to keep track of patterns that you see. Is it a short-term memory issue? Is it a long-term memory issue? Is it both? Are you forgetting parts of or full conversations? Are you forgetting things that you've done recently? Or is it a matter of failing to recognize names, places, or faces? Are you misplacing objects? Are you forgetting how to do daily tasks? And this goes even broader than, are you leaving the stove on unintentionally? This is, do you remember how to tie your shoes? Do you remember how to button a shirt? Do you remember how to attend to your hygiene? Okay. And then, of course, there's the getting lost while driving, which everyone, fears at some point. Next page, please. And again, no one likes to hear this word, but it's very important that we all have a very crystal clear sense of memory loss versus dementia. And again, remember, dementia, which is an umbrella term because there are many variants of dementia out there, this is irreversible, degenerative, and progressive. Okay? This is versus what we call delirium, which is an acute state of confusion or not acting like themselves, which is usually reversible and can be caused by a number of different factors, as you see here. Now, anyone who has baseline memory impairment, as you know, will get worse if an infection like a urinary tract infection or pneumonia starts playing a role. And it's our hope that when we correct these acute insults, that the patient will go back to what we call their baseline mental status, how they were before things took a turn for the worse. And sometimes that happens and sometimes it doesn't. And that's very difficult to predict. Next slide, please. And again, why else are care partners important? So again, Parkinson's disease is progressive, but it is still manageable, okay? Change and progression does not equal the end. I have many patients who are, and maybe your healthcare providers do things a little differently, but I have many patients who get stuck on what stage am I and what's my motor point score? How severe are my motor symptoms from a numeric standpoint? And I try to assure people that that is not what you need to be concerned about. That is technical, medical tools that are not universally used, are not infallible by any means. And that is not what you should be worried about, okay? But there will be times that patients will feel the need to give up, especially if things aren't responding the way they want them to. But we can't let the patients give up. We need to encourage them to stick with their medical visits and counseling, any safety resources or social support, staying active both physically and mentally. The worst thing you can do is let yourself be idle. And again, to stay accountable for your own care as much as possible. One of the things that I love about working with patients with movement disorders versus other areas of neurology, and why I subsequently went into this field, is I find patients with movement disorders to be way more active or willing to be more active in their care. So I see that as a blessing when I encounter that in the clinic or during events such as this. Next slide, please. So again, it all comes down to support. Helping to accept the diagnosis and the need for intervention. Again, don't let yourselves compare yourselves to others, okay? And we need to be firm but gentle about this, okay? When it comes to helping identify the support system, as many of our social worker comrades would say, we need to be able to identify who we can communicate with responsibly and reliably, be it family or friends, okay? And then you as the care partner have a very other important bit to your role about being a patient advocate. Speak up if you think something is wrong or not going well. And the other unfortunate thing is when it comes to patients who are in nursing homes or other care facilities, speak up if the staff there are not following the provider's directions, okay? And this comes into play with medication dose times and schedules, keeping patients active and safe, things of that nature, okay? This is a struggle that both patient and provider have to deal with. And in my experience, there is no medicine that gets messed up with more in a nursing home setting than carbidopa-levodopa, just because of all the rules that are associated with it. Next slide, please. And now it comes to this concept of side-by-side learning, or knowing what you don't know, okay? When it comes to being educated on the symptoms and the disease progression, we want to know what can we expect. And again, don't get hung up on stages or point scales because we treat people, we don't treat numbers. Okay, that's a very important thing to bring up. Now, I spoke earlier about the differences in mentalities geographically, rural versus urban or suburban. I do outreach at a few smaller locations, and not to name names or anything, but I was presented with the challenge that a lot of the patients I see were older and more advanced than I was used to seeing in the suburban setting. And one nurse said to me, of course, because these are people who are not used to going to doctors routinely in their life, because there's nothing else to do in this town except drink and reproduce. Now, admittedly, my first thought was, boy, did I grow up in the wrong town. But my second thought was, okay, I've got some education that I need to do. Next slide, please. And again, knowing what you don't know, proper medication administrations, the rules, how is carbidopa-levodopa best taken? How should the doses be spaced? Time relationship to meals. You all know this. Drug-drug interactions, and then setting realistic expectations about what the medications seem to help with and what they don't help with, okay? And then the potential side effects. And the bottom two are what some of you may be familiar with when it comes to the family of medicines called the dopamine agonists. These are rare but potentially very devastating side effects called impulse control disorders, where people can begin new behaviors like gambling, taking up substance use, becoming hypersexual, things of that nature, things that they themselves may not notice, but it takes their loved one or someone else to point it out. And then the controversial concept of the sleep attack, which is not, I sit down and I'm tired and I can fall asleep. No, it's I'm awake and then boom, I'm out. Okay? And again, while this is a controversial phenomenon, knowing that these things happen to some degree, or if somebody already has a history of substance abuse or some sort of behavior that could predispose them to an impulse control disorder, in that sort of situation, I will avoid dopamine agonists just to lower the risk of these happening. Next slide, please. Knowing the roles of the non-medication therapies, physical therapy, occupational speech. The thing we have to keep reminding ourselves is that these exercises, the therapies don't stop with the end of the formal sessions. You need to keep practicing them once the sessions have concluded. And then, of course, the role of the so-called advanced therapies, the deep brain stimulation or the Duopa pump. Again, we need to be able to communicate clearly and have realistic expectations about what this can do. Okay, next slide, please. The little tricks, okay? Bring a list of the medicines to your appointment. Don't let the patient get away with saying, the little round white pill. There are some doctors who are great at identifying medications like that. I am not one of them. Remember your safety devices. Oh, I use my walker all the time. Okay, where is it? It's in the car. And so other things that if you really have trouble remembering them, write them down, bring a list. That's okay to do. Next slide, please. And as for, again, learning the little tricks, this is a very desperate plea on my part. Please, 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 click, click, click. Please don't ever forget your hearing aids. I know that sounds really goofy and maybe a little condescending, but it can very easily turn a doctor visit into moot. Next slide, please. And again, don't forget that providers can learn from you too, okay? Trust me when I tell you that things aren't always like they are in the medical textbooks, and everyone can benefit from everyone else's experiences. Next slide, please. Now, in the few minutes we have left, I want you all to consider the enormity of everything I've just told you. And now, click, please. Add on top of that we've just had a bomb dropped on us because COVID appeared. Next slide. So take all of the above and mix it in with these beautiful restrictions thanks to the virus. And now we have remote visits, including the phone call visits were unfortunately going away due to insurance purposes, the virtual visits over the counter, and again, over the computer. And again, not everybody has access to a computer or how to use it. And it's very hard to gauge a physical exam over a computer. And then the care partners, can help set up the software or join by phone, HIPAA allowing. Now, again, if we're doing this virtually and somebody is present with the patient, there is this concept of implied consent that the patient automatically gives the provider, an agreement to speak, with the people there. And now the nursing home restrictions, well, I'm not sure how things are going on your guys' side of the eastern side of Wisconsin. Over here, most of our nursing homes are still on lockdown. So no one can come visit and no one can join in the virtual visits. But we can try to get around this if a care partner can potentially join in by speakerphone. Again, HIPAA and compliance allowing. Next slide, please. I'd like to take off my professional hat for just one moment to put on a personal hat and discuss how this affects everybody. Okay, social distancing. Safe, is it necessary? Yes. Is it pleasant? No. Let's be honest and adult about it. Social distancing just sucks sometimes. Next click, please. On the left is a miracle that happened to my wife and I about 15 months ago. This is his 1-year picture. Next click, please. And on the right are the two people responsible for me being here blabbling at you today. They are not in Wisconsin. And the fact that my son can't get held whenever he wants to by his grandparents, again, if you'll forgive my language, it sucks. So I feel this too. Next paragraph. Next PowerPoint, please. So again, finally, what are the needs of the care partners themselves? Okay. You are human. You have limitations, just like the rest of us. We all have a finite amount of energy to draw from. And energy and love are not the same, okay? Our caring for the patient and our love for the patient, that well never runs dry. But our energy and our coping skills, okay, that can sometimes have a bottom, okay? So you do need to take care of yourself, and you need to ask for help when you need it. Boundaries are very important, although very difficult to do. And then on the left-hand side, in the 9 o'clock position in red, is probably the hardest one of all, forgiving yourself, okay? Trust me, I know how difficult this one is, okay? We all want to be able to meet our loved ones' needs at the top of our game for everything they need to 100% perfection rate, okay? We can't, right? You are human beings. I am a human being. We can only do what we can. And next slide, please. As cliche as it is, the airline companies have it correctly. What do they tell you? If there's a loss of oxygen pressure, put on your own mask before assisting others. Now, again, that may run contrary to what our gut tells us to do and what our heart tells us to do. But this is the truth. We need to be able to take care of ourselves before we can take care of them. Next slide, please.
Next slide. Dr. Schonberger, if you want to go through the last two, we'll put those last two on real quick. You guys we'll show them real quick here for you. We're almost done to wrap up, but I'll let you finish those last two slides real quick here.
Okay. Basically, again, the needs of the partners themselves mirror the needs of the patients. Okay, and then finally, the last slide. This all begins at the beginning. We learn how to adapt together over time, know when to ask for help, always stay in touch no matter what, and don't forget, we can learn from you too, okay? We can always learn from you. Don't be afraid to tell us your experience. It may lead to something golden down the line. So thank you all. I apologize for running over.
It's all good, Dr. Schonberger. Great presentation. I think you covered a lot of really good information. I think it was a very personal topic, and we've discussed caregiving a lot, so there were actually no questions submitted. So that tells me you covered everything very, very efficiently for everybody. Or it's 5 minutes to 1 o'clock, it's on the third day, and everybody's having lunch. But you did a great
Sure.
job. We appreciated the humor here. I can tell you that. Some of the comments appreciated your humor on a very difficult topic. So thank you so much for joining us. I know this virtual format is very difficult. We'd rather be in person and have you here, but we really appreciate you taking the time and doing this. And I really couldn't cut off the slide before with your son and your mom and dad, because I really would have felt very bad, because it was such a really cute picture. So thank you for doing that.
Thank you.
Thank you.
Thank you all. Please keep fighting the fight and keep doing it safely.
Thank you. So what we're going to do now is we're going to wrap up. I want to, before I introduce Gary, I just want to thank the three speakers. When I approached them about coming on board to do a virtual program, as well as our vendors, and said it's going to be virtual, it's going to be on it's going to be on a computer, we're not sure what it's going to work like, they all said yes right away. So really appreciate them coming. If you see any of them as your care provider, thank them. They really did a great job, and I appreciate them giving us their time and energy to do this, and their knowledge. I think all 9 presenters did a great job and gave us a lot of really good information today. I also want to thank all of you who have gone to visit the vendors. We will do the drawing on Monday. We'll figure out who won. We will be in contact with you, and we will send out a swag bag for information from WPA, a couple trinkets and things like that for you. So we really do appreciate you giving them their time. We've had a lot of great comments throughout the day on how wonderful the vendors were, how good the discussion was, and we really, really appreciate that. But we're not done yet. I'm going to bring Gary Garland, our executive director, back up here on stage. He has a few things to say for you. And then we also have a video from our board member, Rob McDonald. So Gary, please take the floor. Thank you all. Here's Gary.